from Florence, Italy, where I am actually supposed to be today, but I'm not. Thank you, COVID-19. So good morning or good afternoon, Iacopo, welcome.
Thank you, Lisa. Thank you for having me. Thank you, everybody.
We are really delighted to have you with us today, and we're going to let people populate here over the next minute or so. So we'll just kind of delay and stretch it out so people don't miss opening comments. So just as a recap for people that might be watching this much later down the road, March 26, 2020 puts us smack in the middle of an international pandemic, COVID-19, which the first epicenter we know is China. The second was Italy, and now it's landed in the United States and others. And I got a phone call coming in. And we are going to have a conversation with Dr. Olivotto, who is in Florence, Italy. Thankfully, not the epicenter of COVID in Italy, but he's got a little bit of experience and some perspectives to share. We're going to talk a little bit about HCM patients in Italy, what we know about them, which is very, very limited. We're going to do some lessons learned, and then we're going to get into some hardcore HCM research stuff and ignore COVID for a while. I think it's taken too much attention, even though it's very worthy. So now that we have people starting to join us, Iacopo, thank you so much for taking the time. I know it's a very bizarre time in Italy. So why don't you tell us a little bit about what it's like to live in Italy right now?
Well, it's very weird. As you know, we are not the kind of people that like to sit at home and, we're very social. We like to go out dining at least 5 times a week. That's the legend anyway. So it's really hard for us to be confined, especially we find this very, very hard for the elderly people who are those most at risk. They're more most fragile. I haven't seen my mother personally for about 3 weeks now, and my mother-in-law, I mean, we are having their food brought in, but we are obviously talking on the phone or Skype, but we are not visiting our parents, and the elderly suffer from that very much. And the other class of people who suffer from that, of course, is the very young people who are actually now confined in their homes. They can exercise a little bit around the house. They're not allowed to go out much and to meet with other people. So it's really weird. Everything is empty. And the only shops that are opened are pharmacies and petrol stations and of course food courts. So that's weird. We are coping. I mean, there's a lot of course, social interactions on the web and all the socials. We're catching up with that. We've never been as good as the US people with that. We're catching up with it, and somehow, we're managing. We hope it's not going to last for long, but it will last a little bit longer.
I think it's going to be a little bit longer. How long have you guys been pretty much locked down in quarantine at this point?
So school in Italy closed around the 6th of March. So it's about 20 days now. And then progressively the shutdown became more and more pervasive. And in the last week, it's been like a total shutdown, total lockdown, including you're not actually allowed to move around without not allowed to move around without a good reason. You have to have a piece of paper with you stating what you are actually doing, where you are actually going. And it has to be a good reason, otherwise you may get fined.
And how are you working during this time? Has it changed normal functioning of research and client and patient visits, and what's going on that way?
Yes, everything is pretty much disrupted. All the elective procedures, elective outpatient visits have been suspended. We have tried to we have in some parts of the country, including Lombardy, which is the hardest hit region, where there's actually the vast 40% of our positive patients and our victims are from Lombardy. They have actually made COVID hospitals 100%, and as opposed to non-COVID hospitals. Here, we have decided to have COVID wards inside the same hospital. For example, my hospital is split almost in 2. Half of the hospital is for COVID, and the other half is for other diseases. But we are seeing very few patients coming in without the complaint. So people seem to be staying at home a lot unless they have fever and then they have breathing, or they have very serious illnesses otherwise. All the elective procedures have been suspended. our HCM group, which is usually, it's bustling. It's like 20, 25 people each day interacting with patients and nurses, clinical studies and whatnot. That's all sort of on hold. We are only doing urgent visits. We are keeping on patients, the clinical trials, they're still ongoing. We had discussions at the ethics committee level as to what we should do, but obviously patients who are enrolled in the studies were allowed to continue because for their safety. They come to the hospital, but they need to be, appointments need to be far away, far apart, so that people don't meet too much. We're not allowed to enroll new patients in studies. And most of my work is now for urgent care, urgent patients, and I do ward rounds and emergency room service as well. But it doesn't occupy much. So most of the day, I'm actually doing telemedicine in a way. So that's calls and emails from patients who have loads of questions and loads of fears. And I do my best with the team to make sure everybody gets a fast reply.
So in the time that this has been going on, a good 4 to 6 weeks to certain degrees, and more intensely the last 3 weeks, statistically speaking, there would have been about 125 patients in Italy who happened to have hypertrophic cardiomyopathy, strictly by statistics of number of people affected by COVID. But are you seeing any particular concerns, or has anything come to your attention out of that population that we should take lessons from?
First of all, I believe that there's a lot more positive patients that we are actually aware of. And I also, because if it's true, particularly not we're not beginning to realize, we test more and more, that the number of positive individuals is actually much broader than we thought, and which is good news, because that means that a lot of people have had the virus without having to resort to the hospital, without having major complications, and they were able to sort of basically stay at home with other no symptoms, or sometimes without even realizing they had the disease, particularly children and very young adults. So having said, we are expecting several hundreds, probably HCM patients to develop the viral infection during the outbreak here in Italy, and several thousands worldwide. Having said that, I'm only aware of a single patient with severe comorbidities and who was not so young, who has actually died from COVID in another. But apart from that, my own patients who are in the range of 2000s now, about 2000, I'm not aware of anybody who's actually developed a lot. I mean, we get a lot of emails and calls. They're mostly regarding what to do, what not to do, and how should I behave, go to work, and that sort of thing. But none so far has written to me saying I'm in hospital with this and that, or my brother is in CCU or whatever. So it's really early to say what the deal is with HCM patients in this setting. My feeling and my hope is if you take any other risk patient, hang on, sto in teleconference, ragazzi. My person can account any other risk, like for example, non-cardiac surgery, infections, and chemotherapy, whatnot. HCM patients usually behave very, very well. I mean, they do very well. Their risk is definitely manageable in most instances. So my hope is that, again, in this particular setting, there's probably a majority of HCM patients who are well compensated, who have no congestive symptoms, no pulmonary hypertension, and who may be dealing with the infection reasonably well, or at least have the same sort of risk of major complications as most of the general population. Whereas, of course, there will be a subset of patients who are the most frail, the most sick, who will have an increase in risk, maybe even a substantial increase in risk. However, this is my impression. Of course, there's no way I can have data for that, and there's nothing coming out from China. There's a lot of data from China, but nothing about HCM so far. And we are in the process of collecting data in in an international initiative, which is going to involve a lot of centers, and which will upload data online from patients from the most hit countries, including Europe and US. And hopefully that will give you a lot more information about what's to come, about HCM patients in particular. Remember that the problem with this infection is that to some extent, it is the host reaction that determines the severity of the disease. So the virus is a bad virus. It gives you bad symptoms, gives you like sort of a bad flu-like symptoms, but then only a minority of patients develop pneumonia, particularly the interstitial pneumonia, which is the cause of respiratory failure needing intubation, and then the most likely cause of death in these patients. However, this is, again, most likely influenced by personal propensity rather than the background. Background may be older, obese, hypertensive, have other conditions. This can definitely increase your risk. But to some extent, HCM, in a mild expression, may be able to impact the disease in a sort of milder way. This is my hope. Of course, it's only my idea, so we need confirmation for that. Final thing is, of course, we also are now aware that the virus, besides hitting the lungs, can also damage the heart directly. So there is myocarditis in this disease. There was a paper out in JAMA Cardiology today from China on about 400 patients with COVID, showing that a substantial percentage of these patients have troponin release, which means have some measurable cardiac damage, which to some extent had an influence on the final outcome. So my bias would be that if you have HCM or if you have other genetic heart diseases, you may have a sort of maybe worse equipped to cope with myocarditis if you develop myocarditis. So this is really hard to say.
Can you do me a favor and explain what myocarditis is to our viewers who might not know what that diagnosis is?
Sure. So myocarditis is just a non-specific term, which when I think ending with itis means inflammation. So you can have uveitis, you can have otitis, you can have any inflammation that ends with itis. So myocarditis is an inflammation of the heart, which usually is a response to a viral infection. Viral infection is the most common cause of myocarditis. So that means that the heart becomes is exposed to an inflammatory reaction, and it may be damaged by the virus itself, but most often the virus triggers like a self-inflicted response by the immune system, which actually makes it worse. So most patients with severe myocarditis have damaged their heart because their immune responses are actually sort of reacting against their own heart, and this is why we tend to use immunosuppressants like steroids, for example, in some instances to control it.
So myocarditis can happen from any of the coronaviruses or any virus in general, but in those with HCM, that could have an additional insult to their heart. It's really important that if they have COVID, that they check up with their cardiologist after they've healed and after this is all clear, just to get a baseline. Would that be a good idea?
I think so. I think that they
we're losing.
We know good reasons are really tricky. They're really.
I'm going to have you hold for 1 second. We're having a little bit of a streaming issue. We lost you there for a second, so let's get this back online. And then we'll go back over that again. The question is, should patients with HCM, if they get COVID and they're okay and they're at home and they resolve it, would it be wise for them to make an appointment with their cardiologist in the next few months to check the status of their heart? Uh-oh. We're frozen. We're going to give this a second to clear.
lost you.
Yeah, we're closed for a second. Technical difficulties, please stand by. We'll come back online in a second here. I think we just have a lot of people streaming on the internet these days. And we'll try to get that. Oh, we just lost Dr. Olivotto. I'm going to have him join us back here in just a second. And here he came back. And 1, 2, 3, you're back.
All right. Can you hear me?
Yes, it's much better now.
Okay, good. So yes, I think in response to your question, I think it's a good question. I think, well, first of all, if you develop a fever, let's say you have a fever with no obvious likely to be virus.
We're getting a little choppy again.
Like lost.
We're going to pause again, and we're going to, hi, Dr. Olivotto, and we're going to have him try to reboot. Maybe if you can hear me, Iacopo. Oh, there you are. You're back.
I can hear you. I can hear you, yes.
You go. So they should check in with you after they get better, after a fever.
Yeah. So, well, first of all, if you develop symptoms which are unusual with fever, particularly loss of smell or sense of taste, and if you seem to be breathing not as well as you used to, that might mean that you have the virus on board, and then you should check carefully, possibly your oxygen saturation if you can. There are now devices which cost about $20 to $30 you can get for monitoring your oxygen saturation. That only is necessary if you develop a fever. It's a good idea to contact your doctor. I would not say it's a good idea to make an appointment right now, because it's the less you go out, the better. So unless you have trouble breathing or palpitations or any new symptoms of relevance, I would not advise you to leave home to have any non-urgent visit. That's not a good idea. We are discouraging our patients to come just for checks. But of course, it's good to let your cardiologist know that you have a fever, then you may have a chest infection, and even more so if you feel that your breathing is not as free as it used to be. And of course, once this is over, it'd be nice to have a new appointment. I'm talking about weeks or months from now.
Yeah, in the next 6 months.
Nothing has happened.
Probably a good idea for everybody to check in. We have a question from Marion, and I know who that is.
Yes. Hi, Marion. Hi.
Should we always aggressively try to suppress fever if we get it, or does fever help you get rid of the virus?
Okay, so that's a good question. So in general, the fever is some sort of a weapon we have, because the viruses don't do well at higher temperature. They like our body temperature as it is. So fever, to some extent, is a response. Of course, it's not a good idea to run high temperatures for days, and it's good to use your paracetamol to keep it reasonably low. This virus tends to release a lot of inflammatory mediators like cytokines, and there are even one of our routine protocols in patients who are admitted with the virus is to actually give drugs that will lower your inflammatory status. So in general, I think paracetamol symptoms under control at this point.
So there's been a lot of debate. Oops, we're losing your audio again. It's going to take a second for it to come back. We're having a lot of debate in the US about acetaminophen versus ibuprofen. Which is the best fever reducer for this particular virus, in your opinion?
Well, ibuprofen is a stronger drug. It's more effective. I'm a little concerned because if you have a heart condition, ibuprofen, is not good for your kidneys, and it's not very good for your blood pressure. So in general, paracetamol is a safer drug. However,
which is Tylenol in the United States.
Sorry?
It's Tylenol in the United States.
Tylenol, yes. All right. Yes.
Acetaminophen or Tylenol. Yeah. Different names in different countries. They just try to confuse us. Makes the drug companies feel, that they're keeping us on our toes.
Yes.
Okay. So if anybody else has any other questions, we'll take those questions, but we're going to pivot off of COVID, and we're going to talk about something a bit more HCM focused and trials in HCM. What's happening outside of COVID? What are the trials that are going on now that have you excited or interested or optimistic?
Yeah, I mean, this is the other thing. I mean, that COVID just spoiled a fantastic year, because we have now virtually concluded Explorer, which is the trial on mavacamten in obstructive HCM. Of course, everything is still under lock, so we will have the results. We're supposed to have results presented at the European Society meeting in August. And we're very excited about that, and I do hope the meeting holds. But even in the worst of cases, we'll have a telepresentation of the trial. I'm really very excited. We now have moved from Explorer to the long-term extension of the trial, in which all patients get the drug. As you know, in the Explorer trial, half of the patients have a placebo, and the other half are on the drug. But in the long-term extension, everybody is on the drug. So we, as clinicians, are not blinded, and we are seeing, very exciting, responses from patients. So we're really excited to find out what that has, will tell us, Explorer. Maverick, as you may know, is a similar trial, but performed in patients who are non-obstructive. That has also been completed. It was a US trial, so I did not take part in that. That will be presented online at the ACC sessions.
I'm going to stream it here on Facebook. Hopefully,
oh, good.
To work. I'm going to try to stream it live. So the
unfortunately, it's going to be around 2 or 3 p.m. in the morning for me. So I'm not sure whether I can do that, but I can probably put an alarm clock and see. So we obviously I don't know the details of the study, and we have to wait until the embargo is lifted to know how the study went. Then there's more coming, in the sense that along this trail of negative inotropes, of molecules that will, as I say, will turn your turbocharged engine into a diesel engine, which is what these drugs will try to do, so that you have more mileage. And there's another drug now coming into phase 2 experimentation by Cytokinetics, which is still doesn't have a name. It's just got a CY
whatever. Yeah. The cyto, we call it.
Yeah. We're supposed to start enrolling that very, very soon, and unfortunately, COVID has now made things a little harder for us. But I'm sure that is another thing that will be successfully carried out. And so it's nice to know that there are more and more drugs coming up the pipeline on around this idea that reducing the extra contraction in the heart will not only take away your obstruction, but also normalize a lot of abnormalities that the hypercontraction carries with it, including a lot of energy wasting and a lot of remodeling of the electrical side of things, for example. So I wouldn't be surprised if these drugs, besides improving your symptoms, will also reduce your risk of arrhythmias, for example. This is something we'll have to see. So I think it's really quite, it was supposed to be a super year for HCM research this year, and I hope it stays that way, even with a delay.
I think, based on what I'm hearing, at least out of the FDA in the United States, they've issued guidance on what to do for patients who are in the middle of a trial, and if a trial date comes up, that the FDA is going to work with the sponsor to be as accommodating as possible to ensure that these patients aren't lost in all the work that we've already done. I mean, I've got a number of people who are involved with the HCMA who are 10, 14, 18 weeks into a trial. What was that? Don't be having earthquakes or anything.
No.
Don't be doing that. We have enough drama over there. So I know that the FDA is being very kind about what they're willing to work with. We're supposed to have our patient-focused drug development meeting at the end of April, and we've had to postpone that. And now we're in talks with the FDA to do something that's never been done before, and that is a virtual patient-focused drug development meeting. So I have a call tomorrow with another organization who would be like right behind us in doing that. So we're going to see what we can do. It's not a cardiac, it's a whole different disease state. But if we can continue getting the information out, that means we're going to continue our progress in looking for new treatments and therapies, and ultimately someday maybe even the C word, a cure. But that's way off in the distance. And for right now, we'll just take feeling better. Thank you very much. So
yes, I think that's, what I say to my patient is, if you can feel better and live to be 95, that's fine. I mean, you've defeated the disease. So this is all you have to do. And if you think about it, there is no single except for pericarditis or myocarditis. So infectious diseases involved in the heart, they often cure themselves. But otherwise, there is no single treatment for which there is a cure. Coronary disease, you put stents, which is very nice, but you're not curing the disease. You're treating complications. The disease goes on slowly. You can slow it, but it doesn't. So there's.
We lost you again for a second.
Where cures are beginning to emerge. I'm not saying it's still hard, but several treatments, I would say. In cardiovascular disease, we're still, making a very good job of mending complications, but we're still lacking that degree of. This is for.
We're bouncing in and out of audio again. We're doing that, bouncing in and out of audio. Sorry about that. I do have a couple of questions that I'm going to pose that you're allowed to ask. Any questions now that you want, whether they're general HCM research or COVID. We have a couple of COVID-y questions up here. Sarah, I'm going to take this one on quite easily. How do you distinguish between shortness of breath of HCM and shortness of breath of the virus? She has like two follow-up questions here. How do you know the difference? If it gets markedly worse really quick. Would you agree, doctor? And we just lost Iacopo again.
Yes, but can you hear me?
Now I can.
Oh.
Got ya.
Can you hear me?
Yes. Yes. But you can't.
Yes, you can. Okay. I can hear you. Yes, I can hear you. So yes, it's a very good question. So shortness of breath caused by the heart is usually something that patients know well. It's usually reproducible. It happens in particular circumstances like climbing stairs or after meals. So it would be something you're sort of familiar with, and usually gets worse when you lay down. Whereas in this, and it's usually typically it's related to exercise or movement. With the virus, it seems to be filling fluid. So really, it's like a condition, and you really feel you're always, it changes a lot if you're sitting, and as I say, it desperately worse, and usually quite fast. You remember that usually the shortness of breath doesn't come right away. So you develop the first fever for a few days with chills and muscle cramps, pain. That goes through, then the lungs begin to sort of be involved in a few days. So you usually, typically, short is about 5 to 7 days, or I would say after the initial. It follows the onset of fever.
Okay, Iacopo, we're losing you again. I ask you to maybe reboot the camera again, and I'm going to go and paraphrase everything that you just said. So I'm going to bring you down off the screen. If you can reboot and then come back again, I think we'll clear up that internet connection. Okay, let's give it a second. So that looks like it might work now. 3, 2, 1, and we're back. So you were saying that, and I'm going to paraphrase because it was a little choppy, but I think I probably got it here better than you got it there, and you're frozen again. If the shortness of breath comes out of nowhere, it's probably not COVID. If you have been down for a couple of days with fever, chills, not feeling right, then slowly by about day 5 or 7, the lungs are getting involved, that's more likely to be a COVID reaction as opposed to an HCM, shortness of breath. Was that a good paraphrase?
Absolutely. So,
we're not doing good with the audio. We're losing. So what I'm going to ask you to do, I'm going to ask you if you would be so kind as to log off and then log back in. That might start a new connection and that might clean up the line. And I will address a couple of the questions here while we lose you for just a second. So if you can reboot, like just open up another browser. There you go. He's doing that. Okay. So while he's doing that, I will stay with you for a moment. And hi, you wrote, not a cure, but it would be great with new treatments. Absolutely. We agree 100% with that. And that's what we're trying to do. The question about Madrid, please contact us at the office and we'll help you with that. And Dr. Olivotto is coming back. He's coming back. And 3, 2, 1, and he's back with us. How's the audio?
How's that?
Better. So we have a question. And it is general HCM question. I know HCM is genetic. What is research saying about how likely we are to pass it on to our children? My father's doctor said since he had it, I have it, my children will, that's the word here we're looking at, will have it, and so on. Is there an option for some? Is it in fact, or is there just severity of inheritance? So is it a guarantee that your child will have HCM if you do?
No, of course not. Fortunately not.
So we're having bad audio again. I'm so sorry, everybody. We are dealing with a lot of bandwidth issues. We've lost the audio again. I'm sorry, Iacopo. We'll try this slowly. This might be just not going to be too good today. Patricia said, there's a 50-50 chance of passing it on. Which gene test is the best way to follow if young children? Oh no, you're giving an answer. So would you discuss clinical testing versus genetic testing in families? If we could get that on. Frustrating. We don't have you. Oh, you popped back.
Back.
You're back. You're back.
Yes. So yes. Absolutely, there has a 50% chance getting these from all, which is so every parent can transmit the disease to every child. This is HCM. Other diseases are different. For example, muscular dystrophy. It goes via mothers rather than. So it's every parent can transmit to every child 50% chance of having the gene, which does not mean that he or she will have the disease. Carrier. Most mild parent is severe. It could also be more severe, but usually the more you walk away from the probe, the severe case in the family, the milder cases you get. So I would be more optimistic than what you have started out with.
Right. So if I had a heart transplant, it doesn't mean my daughter's necessarily going to need one, or my niece or my nephew. They're related to me. They might, but that doesn't really change their risk exponentially. And they may have a much more benign presentation, which actually appears to be the case in my family. So this is just an anecdotal case, but that could be
And
happening.
we have no idea why that is. We have no idea why that is. So really still struggling to understand why in the same family, you and your relatives have the 99% of the genes are exactly the same. Why should it be so different? We don't know.
There's probably other background genes and environmental issues and diet issues and all kinds of things that we don't quite understand yet. But hopefully someday, with the continued research of you and your colleagues and our friends, hopefully we'll understand more 10 years from now than we did 10 years ago. That's where we're trying to go. Well, I think we've battled through these audio problems enough, and I'm sure you really want to get back to hanging out with your friends and your I'm sorry, not your friends, your family, because you're.
I wish.
Kids.
Have a beer at the pub.
Yes,
I can't do that.
But very soon, exactly now, my husband and my daughter and I were supposed to be getting to Florence and arriving at our hotel, and in a couple days, getting together with you and the rest of the HCM community in Italy. That meeting has been postponed. I hope postponed, not canceled. And I wish I was there with you in person, but it's nice to speak with you and have you get a chance to speak to the HCMA population via Facebook. And I hope you stay well and your family stays well and you get to see your mom real soon. And I thank you for spending some time with us today.
That was great, Lisa, as always. The meeting will be in November, 21st of November. So you get it in the mail soon. Hopefully everything will be over by then.
21st, Thanksgiving?
Yes. Is it Thanksgiving?
I think it might be.
Oh my God, don't tell me that.
Oh, hold on a minute. I hope it's not. Somebody help. When's Thanksgiving?
We were given a slot without much of a choice.
It's the weekend before. Wait, 1, 2, 3. now I'm like having like a mental block. Is it the third is the third Thursday or the last Thursday? 1, 2, 3. If it's the third Thursday, it's Thanksgiving weekend. If it's the fourth, somebody answer me on Facebook.
I'll check that out for you. I'll check that out for you. Okay.
Okay.
If that doesn't work, we'll have you come especially for a special meeting for you. I promise you that.
Yeah, well, you know what? The way the 2020 is going, a change of plans might not be a bad idea for a holiday. 26th.
All right.
So the 26th. So you're the weekend before Thanksgiving. Thank you, Wendy. I just had a mental block on Thanksgiving.
Good.
So you're the week before Thanksgiving and the week after American Heart Association.
Okay. Yes, exactly. That is it.
Oh boy.
Might work.
Yeah, that might work for me to come over for the meeting, but not necessarily for my family vacation.
That might
if I have to go to Italy twice, sometimes you just got to do these things.
Honestly, you should come any other time to Florence just for vacation.
I know that is actually the plan, and it just happened that this coordinated it, but we will figure it out again. Okay. Oh wait, we have one last question. Hello, I'm French. Sorry for my English. I had a alcohol septal ablation 2 years ago. Is that dangerous for COVID? Post-myectomy COVIDs?
Well, no. I mean, again, if you're in good clinical balance, if you're feeling fine, you may actually have a lesser risk now than you had before if the operation was successful, and you have a better, less lung congestion, less fluid in the heart, less symptoms of heart failure. You may actually be better off now than beforehand, which doesn't mean you shouldn't be careful. So please remember that you should take every precaution to avoid contagion, but hopefully you'll be okay.
There we go. All right. Iacopo, again, thank you so much for your time today. Be safe, be well, and I hope to see you very soon.
Same for you. Thank you very much. Thank you, everybody. Bye-bye.